A sudden postoperative fever is an immediate physiological alarm bell. The surgical team must quickly interpret this symptom and identify exactly which system is failing. While an elevated temperature can simply reflect the body's expected inflammatory response to surgical trauma, it frequently serves as the first visible indicator of an unchecked infection or a catastrophic structural failure. To rapidly narrow down the cause, surgeons rely on a chronological heuristic tied to the postoperative day, or POD. By tracking a patient from the initial incision to day 30, we can map out a predictable cascade of respiratory, vascular, and mechanical breakdowns based entirely on when the fever occurs. The postoperative day timeline provides a predictive diagnostic framework. The specific timing of a fever points directly to a likely anatomical failure, allowing the team to intervene before the complication becomes fatal. On postoperative day 1, the most common source of fever originates in the lungs. The clinical diagnosis is atelectasis. This factor model illustrates the mechanism. After anesthesia, basal alveoli collapse, triggering inflammatory cytokines that spike temperature. A mechanical incentive spirometer requires deep breaths, forcing these collapsed air sacs open and restoring normal ventilation. Patient preparation also dictates pulmonary success. While halting smoking 4 to 6 weeks prior to surgery is the clinical ideal, ceasing even 1 week before the operation measurably reduces the incidence of atelectasis. If the collapsed alveoli remain uncorrected through days 2 and 3, the stagnant fluid creates a breeding ground for bacteria. Atelectasis progresses to pneumonia, and the patient will require antibiotics. Fevers on days 2 and 3 also trace back to the tubes inserted during surgery. Urinary catheterization drives urinary tract infections, which rank as the single most common hospital-acquired infection. Similarly, intravenous cannula sites frequently develop superficial thrombophlebitis, an inflammation of the surface veins that causes localized pain and fever, treatable with topical heparinoids. Early postoperative fevers are the body's surface-level inflammatory reactions to the immediate trauma of anesthesia, intubation, and inserted hardware. By postoperative days 4 and 5, the diagnostic focus shifts away from the lungs and surface tubes, diving deeper into vascular networks and the incisional wound itself. Looking at Virchow's triad, prolonged immobility drives venous stasis, a severe slowing of blood flow that allows dangerous lower limb clots to form. Mechanical interventions like pneumatic compression stockings keep blood moving, but pharmacological low molecular weight heparin remains the definitive preventative choice. If a patient presents with unilateral limb swelling and fever on day 5, clinicians rely on a duplex scan or color Doppler as the gold standard investigation to locate the thrombosis. The second major threat that emerges during the POD 4 and 5 window is the surgical site infection, or SSI. An SSI operates under strict temporal definitions. To be classified as a surgical site infection, it must occur within 30 days of the procedure. If an artificial implant was placed, that window extends to 1 full year. These infections are categorized by depth. Superficial infections involve the skin, deep infections penetrate the fascia, and organ space infections breach internal cavities. Days 4 and 5 represent a tipping point. The unseen failures of preventative measures taken inside the operating room finally manifest as visible clinical crises. To understand why a surgical site infection blooms on day 5, we have to flash back to the operating theater, exactly 60 minutes before the surgeon's scalpel touches the patient's skin. This graph maps the decisive period, the 4-hour window from incision to bacterial colonization. Antibiotic concentrations must peak as skin is breached. Administered 60 minutes prior, the drug must be redosed precisely at the 4-hour mark to keep tissue concentrations above the bacterial threshold. Yet, despite exacting pharmacology, the single most critical variable in preventing an SSI is mechanical, a meticulous 2 to 3 minute surgical hand wash. Preoperative skin preparation follows similarly strict rules. Hair at the surgical site must be clipped, never shaved, because razors leave microscopic abrasions that harbor infectious bacteria.
For chemical preparation, a combination of chlorhexidine and alcohol is the superior antiseptic agent, measurably outperforming traditional betadine. The operating theater maintains rigid environmental physics, positive pressure to push contaminants outward, laminar airflow from clean to dirty, and 4 fresh air changes hourly. Wounds are categorized into 4 classes: clean, clean contaminated, contaminated, and dirty. This classification dictates the statistical probability of an SSI and whether postoperative antibiotics are even necessary. A major break in sterile technique during a routine clean procedure instantly downgrades the wound to contaminated, multiplying the patient's baseline risk of infection. A day 5 infection is rarely random. It is the mathematical consequence of failing to control the precise variables during the decisive operative window. Moving the timeline forward to postoperative day 6, the diagnostic focus pivots from biological pathogens to raw physics and mechanical tension. The severe complication of this stage is abdominal wound dehiscence, commonly known as a burst abdomen. This is the catastrophic structural failure where the sutured rectus sheath splits open. Triggered by a postoperative cough, a sudden spike in intra-abdominal pressure forces a discharge of reddish, serous fluid that rapidly soaks the surgical dressing. Clinicians recognize this specific presentation as the salmon fluid sign. It is the definitive physical proof that the internal abdominal layers have given way. Definitive management requires emergency resuturing in the operating theater, governed by Jenkins' theory. To safely distribute mechanical tension, the continuous suture length must be at least 4 times the wound length. A day 6 burst abdomen demonstrates that successful patient recovery relies just as heavily on structural engineering principles as it does on modern antibiotics. By day 7 and beyond, surface-level explanations for fever are largely exhausted. Postoperative sepsis appearing this late typically hides deep within the body's internal cavities. The primary culprit for late-stage fever is an intra-abdominal abscess, a walled-off pocket of infected fluid pooling inside the peritoneal cavity. Tracking these abscesses requires understanding gravity. In this cross-section, for supine patients, fluid naturally drains into the right hepatorenal space, or Morson's pouch. For ambulatory patients standing upright, gravity pulls the infection down into the pelvis, settling in the pouch of Douglas. This pelvic pooling creates a highly specific clinical symptom, pelvic diarrhea. The physical mass of the abscess irritates the rectum, causing an intense urge to pass stool, but they only pass mucus. Locating these deep collections requires a contrast-enhanced CT scan of the abdomen. Once identified, definitive treatment is drainage via a pigtail catheter inserted under precise ultrasound or CT guidance. Late-stage fevers require advanced imaging interventions because internal anatomy and basic gravity conspire to hide the most dangerous complications completely out of plain sight. The postoperative day timeline provides a structured diagnostic algorithm. Day 1 fevers point to the lungs. Midweek fevers trace back to deep veins and incisional infections. Day 6 reveals raw mechanical failures, and Day 7 exposes deep anatomical abscesses. But while this chronological framework is an invaluable investigative tool, biological timelines are not absolute laws. An infection can break the rules and present out of sequence. Regardless of when the complication appears, the root cause usually lies in the past. Treating a severe infection on day 5 or day 7 almost always traces back to a breakdown in protocol during that 4-hour decisive period in the operating theater. Delivering the highest level of surgical care demands treating the preoperative preparations, from antibiotic timing to hand hygiene and hair clipping, with the exact same clinical rigor as the physical surgery. Surgical mastery requires managing the physiological cascade of the 30-day recovery window with the same precision applied to the physical repair performed in the operating theater. Successful outcomes depend on accurately predicting and preempting these consequences before they manifest at the bedside.